This is the EMS Research Vlog and Podcast, where we talk about the research-related issues that matter to those who work or study in the area of emergency medical services. Your host is Bram Duffy, who is a paramedic and communications professor.
Hello and welcome to the show. We're talking about something that affects every single one of us on the truck, which is workplace violence. And we all know that dealing with aggressive or violent patients is a real risk. It's often just called part of the job, but that doesn't make it okay. And today we're going to break down a new research study that gives us a simple, fast tool to help spot these risks early. It's called the ABRAT-EMS, and it could be a game changer for our safety. And so let's start with why this even matters. We all have stories. A patient becoming threatening, a situation that escalates out of nowhere. Gosh, statistics show that violence against EMS clinicians is a real serious problem, and it's also getting worse. A lot of this violence is linked to behavioral health emergencies, substance abuse, or there are mental conditions like delirium that can cause problems like that. But we often don't report these incidences. And like I said, we might just think it's part of the job, or we might feel sorry for the person. And plus, many agencies don't have great policies for reporting. And this makes it hard to track down how big the problem really is. We need a quick way to assess a patient's potential for violence right when we arrive on the scene. And that's what this study is all about. I found this article called Aggressive Behavior Risk Assessment Tool for Emergency Medical Services. It was published in the JACEP Open, and they conducted a study between March and April of 2024 with two private EMS agencies. And over that time, they gathered data of more than 9,000 patient encounters. EMS crews worked to use a checklist that helped assess patients for certain behaviors before transport. So then what they did was record any violent events that happened, like physical threats or assaults or harassment. The goal was to see if they could create a short, reliable screening tool that, from a longer one that was used in emergency departments. And from all that data, they developed the ABRAT EMS. And the ABRAT EMS is simple. It's like this 3-item checklist. It's designed to be used quickly during your initial patient assessment. So the 3 things that they talk about looking for are agitation, confusion, and then aggressive or threatening type behavior. And each item has a point value or a weight that's based on how strongly that might prevent or that might predict violence. So confusion gets 1 point, agitation gets 2 points, and then aggressive or threatening behavior gets a 4 point. And you just add up the points for the behaviors you see. The total score puts the patient into a risk category. So a score of 0 would be no risk or a low risk. And then if we have a score that's 1 to 3, we're going to consider that person in a more a more medium kind of risk category. A score of 4 or more is a high risk. And so we know just from talking about if we get aggressive or threatening behavior, that gets 4 points. So that's, an automatic when we're thinking about, how the scale works. So, for example, if a patient is just confused, then their score is 1. There's a medium risk there, right? And if they're agitated and confused, then their score would be a 3, because that would mark a medium risk. If they're only showing aggressive behavior, then their score is a 4. And that does, like I mentioned, show that there's a high risk. Being agitated and aggressive would add up all those points, right? And it'd be 6 for high risk. So when they looked at this as a research project, they did a study and found that 1 out of every 100 patients had a violent event. And that confirms that this is a common issue. So if you already are working on, you don't need a research project to tell you that. But when they used this ABRAT-EMS tool to identify risk, it performed really well. So it was about 83% accurate at identifying patients who would become violent. And it was also about 88% accurate at identifying patients who would not become violent. So, in simple terms, it's good at flagging potential trouble without raising too many false alarms. So, here's a key finding. For patients with a score of 4 or higher, about 1/3 of those ended up being violent. So, that's a significant number. On the flip side, if a patient scored less than 4, it was almost certain that they would remain nonviolent. So this tells us that that tool is very reliable for ruling out risk. What do you actually do with a score in the field? Well, this is the most important part. The score gives you a way to act proactively. So if your patient has no risk or a zero, then you can proceed with just normal care, but we, of course, maintain our situational awareness. If we have a patient that becomes a medium risk in that 1 to 3, then it's time to increase your vigilance, right? Think about things like de-escalation techniques, how we speak calmly and clearly sometimes to help. And if your patient has a high risk, which would be 4 or more, then it tells you to take immediate steps to protect everyone. And I understand that when we are trained, it is an almost automatic that we think about scene safety. And scene safety is a thing that is passes through our head, and that's great. But what this does is allows us to sort of qualify that. Today, I have Dr. Chae Kim and Kathie Dunn, who are both nurse researchers here with us because they were the lead authors on the study and here to talk with us more about the tool.
Thank you for this opportunity. My name is Sanjay Kim. I'm a PhD and I'm a nurse educator. I've been involved with how to prevent patient violence, workplace violence in healthcare setting over about 15 years. And so what I learned is that screening patient is important so that we can provide targeted preventive measure for that high-risk patient. But what I found that there's not many validated screening tool to identify potentially violent patients. That's why I initiate this ABRAT, Arrest Behavior Risk Assessment tool in hospital setting. But what I learned throughout the process, we need to have a more specific ABRAT for specific patient population. We cannot use one tool for all patients. So we have developed ABRAT for emergency department ED, ABRAT for H, hospitalized inpatient setting. We have an ABRAT for long-term care home, and then we have ABRAT for EMS. So very specific. Now for this study for EMS, again, we all know the negative impact of patient violence on EMS clinicians there, but there's not any validated violence screening tool. So what we did, we adopt ABRAT emergency ED because it's very similar patient, think about that care that's being provided. So we adopted from there, and then it has 3 categories, like a history, previous history, and then violent behavior indicator that we can assess on the field. And then we also have, from the ED study, we found out the reason for ED visit, very important. That's big indicator. There was very interesting findings. So we adopt that tool for EMS, pre-hospital setting. So we change it to dispatch reasons. We changed a little bit. So that's how we came out with the ABRAT-EMS. But any tool development, we start with the big number. So we have about 7 items, but way too many for busy EMS clinician. So part of the tool development validation study, we need to reduce number of items. We call parsimonious setup item. So that's the kind of validation study we did it with this paper publications. And then it came out in the busy, chaotic environment. The clinician, EMS clinician, they do not have a time to ask past medical history, like, previous aggression history or mental illness, even for dispatch reason, didn't really affect. For them, just quick assessment. So that's the result that we have 3 items. The other part, I want to also mention that screening is important, but what we found out throughout the previous paper, we don't have a lot of clearly written definition of violent event. It's very unclear definition. Everybody kind of having their own perceptions because there's not any validated tool that measure patient violence. So throughout the ABRAT study, we recognize not only screening tool, we need to have a tool for assessing violent event types. So we have a new definition came out from the Joint Commission about what is violent event. So based on that documentation, we developed violent event severity tool, not only violent event type, but also severity. So that's called VEST. So those tools are being used as a companion tool. ABRAT for screening tool, VEST for outcome measure, that only the type severity from grade 1 to grade 4, mild to life-threatening for each different type. So we use those tools for this study, for EMS study as a part of the tool. So that's kind of where we are. But again, what is the next step for having this tool? Why so important? We need to have preventive measure based on the score. We need to have that's the ultimate goal for this tool development. So that based on the screening tool, what are we doing it? What are the preventive measures? So we do have that evidence now, not only the tool development, but proactive, targeted to high-risk patient based on the score, high-scoring patient. We have evidence now having preventive measure before the event occur. It really reduced violent event in emergency department setting, also hospitalized patients. So that's kind of direction we are going. But tool itself, beginning stage.
Let's continue to dig into this more, because you also have Kathie Dunn with you, who wrote the article with you. Let me give you a chance to jump in. Kathie, introduce yourself to everyone and tell us more about the problems that you were solving with this.
Thanks so much. Appreciate the opportunity to be here and to speak about this really important topic. And you already touched on it. We were anecdotally seeing increasing violence in the workplace, and the trajectory being what the statistics have told us, that it's most commonly the patient to provider. So I'm the clinical director. I'm a director of clinical practices nationally for global medical response. And we have about 35,000, between 34 and 35,000 providers under our umbrella. We do about 6 million transports a year in the US. And we also do some international transport by air as well. So we have air and ground entities, and in both, we were seeing an increase in the violent events and elopements of patients that were with just catastrophic outcomes. And we've seen them in the news. It's really rare these days to go a week without seeing some violence against EMS in the workplace, in news and social media. There was a paucity of literature. There were pockets of pieces, but nothing that spoke to the proactive, and like you spoke to, the ability for us to use a validated tool to try to mitigate the risk for transport before we even depart the scene or the referring facility. And so looking at scene and interfacility patients, we chose the two. We said, hey, I contacted Dr. Sun, and she was just so gracious and amazing and willing to do this work with us, because it's a lot of work on her end to do this with us. And she agreed to do so. And so we were very intentional about choosing a Northeast entity, both private because we own them and we're a private company, but still very heavily 911 in the Northeast, and then very heavily IFT in the Southwest. And we chose those spaces specifically trying to get them as far away from each other, but also trying to capture N numbers as quick as we could, knowing we'd be running a sprint as we were capturing this data and collating this data and trying to get minimally, we really wanted to get an 80 to 85% capture rate. We knew we would have some misses, and our crew did not disappoint. We had a 90% capture rate of all calls of the over 10,000 that were collected. And then meeting inclusive criteria, we had 9,024. So just over 9,000 was the end number for the study, which is phenomenal in just 2 months. So you can imagine the mad dash that we did to get our crew on board to collect this data. And we wanted to just throw it against the wall and see what stuck. And sure enough, it was pretty, like you mentioned, it was pretty impressive and statistically significant to have the 83% sensitivity and the 88% specificity. That's just, we don't have a single stroke scale that meets those sensitivity and specificity percentages. So we were really impressed with that. The next step, obviously, as Dr. Kim mentioned, is to look at making it prescriptive. Can we create this tool, make it prescriptive? So if you are low risk of 0, it's green, no changes. If you are moderate risk, in the yellow, 1 to 3 score, what changes could you make that fit in that category? This would be prescriptive, and we would need medical directed buy-in, et cetera. There are regs and oversight entities that may cause us some barrier or restriction in how much we're able to do proactively. But the more literature and more scientific method we use to get this data out there gives us a stronger argument to promote changes in the regulations and the restrictions in, say, restraint use in some areas.
Yeah, and so a lot of times it's kind of fun because we try to find like the qualitative aspect to an issue through a qualitative means, but this is not that way. And this time, you used a quantitative thing to find the quality of something. Dr. Kim, let me go back to you and ask, gosh, Dr. Kim, it's like, why is having this formal risk assessment tool better than the paramedic just relying on a gut feeling? Why is that gut feeling not enough?
And we need to, okay, so a lot of issue we are encountering underreporting. When not reporting, because a lot of gut feeling, everybody a different definition. We need to use standardized form. So even for violent risk assessment, ABRAT. So you have a scoring system, objectively screen the patient, identify who's at risk. That's important. Not only that, violent event, like in our study, we collect physical assault, physical threat, sexual harassment in our tool. So we got 2 tools. Remember, we got companion tool. We also use operational definitions. It's not a gut feeling. My definition may be different from your definition of a physical assault, right? And then we also, each violent event, we have a degree, mild, moderate, severe, life-threatening. So we provide operational definitions. So it's a objective, standardized manner we collect. And we collect real time. Not a lot of study what we have is recalled by base. Did you experience physical patient assault? It's like what happened previous. But with this tool, having the tool using at real time, we can collect real time incidents. And then the other benefit, we can track trend and we can monitor that incidents, and we can monitor effect of our preventive measure. So that's how we report and evaluate, and then based on that, policy and procedure can come out. So we all do in standardized manner. So having that tool that's the purpose of that.
Yeah. And so, Kathie, can you tell me, you had 9,000 patient encounters. And so walk me through how crews on the ground participated in that. How did that go down?
Sure. So we did a presentation, and we initially, for the managers and the champions, we chose champions at each site, and did a presentation on the background and what we were seeing, and statistically, the increase that is in our literature now of healthcare being the number one. 75% of all reports, according to OSHA and NIOSH, are in the what is the board? Bureau of Labor Statistics. 75% of reports of violent events in the workplace are healthcare related. And so we did that presentation for our people and said, we have the opportunity to do this research. And so we got buy-in first, and they were all about it. We got the buy-in first, got the right people on the bus to help promote it. And then we developed a QR code to make it as simple as possible. They all use phones in their workplace or iPads in their workplace. And so we knew they would be able, just by company issued devices, to access the QR code to make it as simple as possible. Developed the tool in an algorithmic type form, asking the questions. And so if there was no problem, it would automatically auto-populate to the end of the study. If there were problems, then it would continue to pull in different questions. So even in the design of the survey that we had them complete for every encounter, we were very purposeful in how we did that, because how busy EMS is. I mean, they just do call after call after call, and ask them to do one extra thing, we had to do our diligence in making it as simple for them as possible. We also provided them a survey link. I can tell you 99.8% use the QR code. It's just so simple.
Dr. Kim, can you tell me about these 3 areas? Because the final tool has just 3 items that you're looking at, right? And so it's agitation, confusion, and then like this aggressive, threatening behavior. How did we land on those kinds of things? Like, how did you land on those 3?
Okay, so any tool development, you start with a little larger number, and then we use a special statistical procedure called multivariable logistic regression. That procedure will be helpful to identify those significant predictor of violent event independently. So that's the power of logistic regression. So from there, those 3 items came out significant predictor. And then the result is the odds ratio. So based on the odds ratio, we assigned number value depending on how far they are. So we assign 1 for confusion, score of 2 for agitation, score 4 aggressive threatening behavior, and then they automatically calculate total score. That's how we came out. Again, we got parsimonious set of items, make it easy and simple tool for busy clinicians. So that's how we came out with the tool development.
Awesome. So, Kathie, can you tell me, how does this tool account for patients that have conditions like dementia, or folks that might be inebriated? These folks that confusion is kind of their norm. How does it work for those folks?
Sure. I'm so glad you brought this up, because it is so often, and I think you touched upon this and alluded to this in the beginning of this podcast, it is often that patients who medically become combative or aggressive, we are much more forgiving and don't see it as a problem. And so that is even more underreported than a patient who is behaviorally violent. And so the confusion, I think we captured a percentage of these patients just because their reason for becoming aggressive or violent is a medical etiology doesn't mean that it's any less impactful on our providers. It's just as impactful. Our providers are still experiencing the violence, and so we need to capture that. And it is something that we looked at when we were coming up with a prescriptive model to say, if you're in the yellow, you have got to rule out medical first and treat the medical before the chemical sedation or the physical restraints and, the de-escalation techniques always.
But
So
at the end of the
looking at the
day, you're
medical
just
piece,
caring about what comes out, not necessarily the
etiology.
Yeah.
And you're so spot on to even talk about that, because historically we are so forgiving. I mean, I know one encounter, I was 3,000 feet in the air and the patient became absolutely violent. We had to land on a beach. And the first thing I said when the firefighter was there to pull the patient off my lap was, it's not his fault. We could have crashed. He could have crashed. He was out of his litter. He was out. And we could have crashed. And my first response was, it's not his fault. It's not his fault. He had really, really significant hypertension and we got the better of him. But we can still be forgiving, but it doesn't mean that we don't capture it and that it's not a violent event. It's still a violent event and it still lands.
Well, lands lit, in your case, the airplane. So how much training does it take for a medic to become proficient with this?
Oh my gosh. Our EMS people are so brilliant and they are quick adopters and they're quick studies. Less than 10 minutes, I can tell you, they had this down. The important piece was, as Dr. Kim alluded to, the definitions, clearly defining all the different pieces of the assessment period, for instance. So we define the assessment period from when you meet the patient to when the patient sits on your litter or first touches your litter before the belts go on. And so we clearly even defined that time period without putting a time limit on it. Because for some of us, that might be 60 seconds. And for some of us, that might be 60 minutes. Right? It depends on where we are. And so we didn't time delineate that per se, but we did give it a term. So making sure that we were giving very clear direction and expectation. And the way the tools have been designed, both the ABRAT and the VEST tool, the way they've been designed just gives so much clarity to the definitions that there were no questions and we didn't have any problems at all. And our EMS people are just such amazing quick studies.
Well, I appreciate what you're doing is fantastic. And so just to reiterate, you guys are awesome. Glad that you're making new tools. Thank you, Dr. Chae Kim and Kathie Dunn, for joining me today. It's really good to have you to talk about this tool.
Thank you so much for having us.
Thank you very much.
Like many of you, I'm also an EMS instructor, so I know what it's like to have topics that are important to cover, but are not actually in your curriculum. So when it comes to EMS research, I want you to know that I've been joining EMS classes lately in a virtual kind of way. It's fun for me to meet your students and talk about EMS research, or even talk about how things are done differently where I am versus where you are. So if you're an EMS instructor like me and you want to give your students a flair of what EMS research is all about, just fill out the inquiry form on my website at professorbram.com. This is professorbram.com, and I'll be in touch. I want to also invite you to check out my latest book. I co-authored it with 4 Arrows, who has 2 doctorates and is an expert on indigenous scholarship and hypnosis.
We've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others. no matter how self-reliant we are, if we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and
Right.
you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state.
I want to invite you to check it out because we introduce a method for communicating with patients on the scene of the emergency that takes advantage of some of the properties found in hypnosis. The book works to change the way we approach and interact with any emergency patient who's in acute distress, and it can help you be a better practitioner. The book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. Follow a link there below to find it, or you could get it almost anywhere books are sold. And if you contact me, I would be happy to mail you an autograph sticker designed to be put into the jacket cover.
Hi, I'm Will Chaplot from the International Pre-Hospital Medicine Institute. You might know about us because of the literature reviews that we post every month free to review on our website at iphmi.com and also published through GEMS Online Magazine every month. We've been doing them for 5 years, so now we've accumulated over 240 literature reviews over the past 5 years. And we've gotten feedback from our audience that said they'd like to have these things as desk references, so they'd had a rapid reference. Well, we've done it. And there are now 5 volumes of these books, one for each year that we've been publishing them. This is the latest version, volume 5. And as I said, in each of these, there's at least 48 literature reviews. They're all cataloged in the beginning of the book, so you can see what the topic area is, what pages those reviews are on, and how you can find them quickly. And again, these are a great reference, whether you're putting a lecture together, working on a paper, studying, whatever it is. This gives you the depth of field of the science that dictates what we do in the field, or what we should be doing in the field, or why we've changed the way we do things in the field. In any event, as with all of our publications, we've priced these because we want you to be able to have this book. It's only $4.99 in the hard copy here, and they're all 5 of them are available at that price. But you can also get them as ebooks, and they're available as ebooks from Amazon, from Apple, from Barnes and Noble, wherever you get your ebooks for the price of $2.99. So again, we don't do this with an aim towards getting wealthy. We do these because we want you guys to be able to have these materials, relevant information, affordable information, and an access so you can get to it. So you want the hard copies, go on Amazon, $4.99. Go to your ebook store and you get it for $2.99. If you're in the business, this is the kind of material you want to have around to settle those firehouse arguments or to help you put your materials together. Thanks again. See you all soon.
I'm doing a research project related to first responders who live in the United States, and I could use your help if you don't mind being interviewed over a video call. Go to my website and fill out the form. It's at professorbram.com, professorbram.com. I just want to thank you for listening, and I look forward to sharing more insights with you in the next episode. If you enjoy EMS research, please tell your friends and like, share, and subscribe to help others get the message.